Thank you, Heidi, and welcome back everybody to this Tuesday evening session. I'm pleased to say it's even been sunny in Birmingham today, although we're starting to go dark a little bit at this moment in time. We had a great lunchtime session and I'm really looking forward to this evening. We have two more wonderful speakers. I'm going to get straight into this evening session. Our first speaker is Sarah Adams, and Sarah is lead dietitian of the Scottish Service for Inherited Metabolic Disease. Sarah's working in Glasgow. She has a lot of experience, 22 years experience now, and most of this has been working in inherited metabolic disorders. She's worked both in pediatrics and adult disorders, but mainly adult at this moment in time. She has a lot of experience of caring for pregnant women with PKU, and certainly she works very hard to get them to adhere to dietary treatment. So the title of her presentation today is very fitting. It's entitled Overcoming Challenges to Adherence in PKU Pregnancies.
Hello, my name's Sarah Adam. I'm the lead metabolic dietitian for the newly formed Scottish DMIMD service. And today I'm going to be talking about pregnancy and PKU, understanding and overcoming challenges to dietary adherence. I was initially invited to present a challenging case study on maternal PKU that had some social work involvement. And although I've had recent experience of this, I felt obtaining informed consent would be difficult as a patient might not fully understand the implications. Therefore, I thought it would be useful to explore more generally the barriers to adherence during pregnancy in PKU, the psychosocial issues and the fears women with PKU have around family planning to help guide our strategies for understanding and overcoming challenges to adherence in pregnancy, and include some discussion around social work involvement. So here's my disclaimer. I had sole editorial control over the content, and any views and opinions and recommendations are solely my own. The dietary management of PKU during pregnancy is highly challenging and of critical importance. Blood phenylalanine must be tightly controlled in pregnancy as high levels are teratogenic and can cause congenital heart disease, mental retardation, low birth weight, and spontaneous miscarriage. Dietary treatment will protect the fetus, but only under the proper circumstances. Maximum protection is offered when metabolic control of phenylalanine is attained prior to pregnancy and maintained throughout. The recommendations are that all PKU pregnancies should be planned so women are established on their diet and have metabolic control prior to conception. The target treatment range for phenylalanine in pregnancy and prior to pregnancy is 120 to 360 micromoles per litre or 2 to 6 milligrams per deciliter, as recommended by the European and US guidelines for PKU. Treatment started within the first trimester may not prevent some of the adverse effects, but good pregnancy outcomes can still be achieved if phenylalanine control is achieved by 8 to 10 weeks gestation. Although many women are highly motivated and sustain the diet extremely well prior to and throughout their pregnancy, experiences show cooperation with the metabolic team and adherence to dietary management can be poor with affected babies still being born. Poor adherence risks a second-generation effect, thereby reducing the great success of newborn screening. So we need to understand the challenges women face and look at the best ways to help support and advise women to protect their unborn child. Brown et al. In 2002 identified a number of common barriers to dietary adherence before and during pregnancy. Some women haven't been on diet since childhood. The diet is time intensive and rigorous attention to detail is required. Many find the prescribed foods and protein substitutes unpalatable. There can be difficulty accessing medical care, such as long commutes to the clinic or taking unpaid time off work to attend multiple appointments, particularly when dependent on public transport. This study was done in the US, and the average travel time was 1 3/4 hours, with a range of 15 minutes to 5 hours. We don't have that information reported for the UK, but this is similar for our patients due to the geographical area that we cover. Travel time could range between 15 minutes to at least 4 hours. Pregnancy-related nausea and vomiting affects the ability to stay on the diet. There are increased costs to some for prescriptions and also for travel. And demographic barriers were frequently a single mother, those under 21 years of age and having low IQ. And in my experience, unsupported and poor understanding family members. And we know that overall the diet for PKU can be a burden. It's inconvenient, unsociable. There can be embarrassment as it's obvious to others when eating out of the home, for example, at work. Some patients report that they feel well despite not adhering to the diet. Some patients have lost contact with the metabolic clinic, where others are new to the service or even the country, such as migrants and asylum seekers who have their own set of challenges navigating the healthcare system. Lowered IQ and memories of their experience in PKU clinics as children can add to their difficulties adhering to recommendations, recalling having to get their bloods taken, having to take large volume of old style protein substitutes and a limited range of products. Over the past 12 years working in adult PKU, I've experienced in managing 35 women who've become pregnant, and some will have had more than the one pregnancy in that time. In a recent audit of our pregnancies, 55% were planned and 45% were unplanned, which appears good when we know in the UK that more than half of all pregnancies are unplanned, remembering that this doesn't always mean unwanted. Of these unplanned pregnancies, common themes of poor adherence that I have seen include long distance to clinic, infection or illness, such as repeated urinary tract infections that required hospital admission, and even dental pain, including failure to seek treatment. There's been an element of learning difficulties. They may have had previous children, all of whom have been unplanned. Some have been under 22 years of age. They've been usually unemployed or in low-paid work. And the father hasn't been present at appointments, which may suggest a lack of support within their relationship. The nature of the diet is rigorous and intensive and provides an additional stress when trying to conceive. Patients could remain on the preconception diet for weeks or months before conceiving, considering the average length of time for a couple to conceive once they actively start trying is approximately 1 year. Blood samples need to be sent 2 to 3 times a week to achieve tight control. An unpalatable protein substitute needs to be consumed 3 to 4 times a day. Patients need to be organised with prescriptions and have a good range of low protein prescribed foods for sufficient energy and variety. An adequate energy intakes need to be maintained, and being imaginative with meals helps maintain interest. Taking time off work or juggling family commitments to attend numerous appointments for metabolic, midwife and obstetrician. They need to plan in and calculate exchange foods and maintain food diaries to help keep track of their intake and exchanges. And they may have to maintain the diet. They will have to maintain their diet through pregnancy-related nausea and vomiting. And on top of all this, the mother may have employment or other children or other carer commitments to deal with. So it's understandable that women find it extremely difficult to adhere to diet, and health professionals need to be sensitive to this. Catabolism related to poor energy intakes from pregnancy-related nausea and vomiting can increase phenylalanine levels, and it is therefore essential patients consume adequate calories from low-protein food, aspartame-free sugary drinks, and sustain the protein substitute to achieve and maintain the desired Phe levels. The European guidelines recommend aggressive intervention with hospital admission for IV fluids and nasogastric feeding to aid phenylalanine control, but offer minimum advice on the use of antiemetics. However, units may not always have the ability to admit women. In my recent experience of managing an admission for hyperemesis, we had difficulty with specialisation and de-skilling of the ward midwives, such that no one was able or willing to pass an NG tube, and they were unfamiliar with the use of enteral feeding pumps. A specialist nutrition nurse did place the NG, but there were challenges during the patient's stay. If it happened again, we would try and admit to a general medical ward rather than a maternity ward. Calland Hansen et al. From Charles Dent Metabolic Unit in London gave a case study presentation on the use of antiemetics for hyperemesis gravidarum. She showed the combination of aggressive dietary management with low threshold for the use of antiemetics. If one doesn't work, try another, showed quick resolution of high Phe levels and dietary intake. From this, I highlight to patients early on that this can be a risk and to contact their GP and metabolic dietitian as soon as they start to get nausea, so antiemetics can be started sooner rather than later. Gastrostomy and jejunostomy feeding tubes have been used with hyperemesis gravidarum. They've been shown to improve nutritional status and normal birth outcomes. Gastrostomy tube placement could be an option to deliver protein substitute to women who are unable to restart the diet due to severe nausea or palatability issues. Scott Schroeder et al. 2012 described 2 cases in PKU pregnancy in which a gastrostomy tube was placed after other measures, including trialling different forms of protein substitute, sapropterin, regular ondansetron, failed to control Phe levels as they were unable to consume and tolerate the protein substitute. In both, the gastrostomy was placed at 13 weeks gestation. One had a continuous overnight feed, and the other had 4 bolus feeds of her protein substitute during the day. Phenylalanine levels improved and they had normal birth outcomes. However, the authors recommended that motivation and compliance needs to be assessed before tube placement. Psychosocial issues also play a role in adherence. Susan Weisbrunn et al. Discovered that strong social support from family and medical providers increased the chance women would start treatment before pregnancy. This support was practical as well as emotional, for example, helping to prepare their protein formula or perform their blood tests. However, despite getting family support, those who relied too much on parental support did less well throughout their pregnancy. Women with positive feelings about the diet maintained metabolic control better than those with negative feelings. And those who felt they didn't get adequate support from their health professionals and those who believed their circumstances were controlled by chance were less likely to control phenylalanine levels. A recent UK survey in 2018 by the NSPKU dietitian Suzanne Ford and her colleagues reported the experiences of 300 women aged 18 years and over with PKU have around psychosocial development, preconception, pregnancy, and postnatally. It provides a greater insight and understanding of women's fears and anxieties around family planning. Pregnancy should be a time of positive emotions, but for maternal PKU, it seems to be a source of feelings of negativity, ambivalence, distress, and for some, alarm. When women become pregnant, without following dietary treatment, they express feelings of shock, guilt, and being overwhelmed. Perhaps for some women, reluctance to initiate the diet prior to conception was a lack of privacy, as if it were a public declaration of intent to have a child. Others described heightened anxiety, worrying about every Phe level above or below the target range, or were disturbed by any delay in receiving their results. Severe morning sickness, particularly when prolonged and having a negative impact on their metabolic control, also caused anxiety. Some reported struggling to count exchanges and consume sufficient calories. Some women had inadequate or intermittent access to low-protein foods. And this survey reported that strong social support from a partner or family appeared critical to success. The report recommended that healthcare providers should be sensitive to the distress and anxiety experienced by women, and that women should be offered psychological, genetic, and family planning counselling. Couples often want to know the chances of having a child with PKU. A high level of care should continue postnatally to prevent the symptoms of high levels at an already difficult time with a new baby. Non-dietary treatments such as sapropterin should be offered pre-conception and postnatally to ease the burden. None of the women in the survey were offered this medication. In responsive women, it may lessen the time to achieve acceptable metabolic control prior to pregnancy, and postnatally may lessen any PKU-related symptoms during an already difficult time with a new baby. Currently in the UK, sapropterin is only licensed for use in pregnant women who struggle to maintain phenylalanine control and is a last resort. Our adult service does not have psychology support, and I often struggle to know what more I can do within my capability to counsel and motivate a patient to follow our advice. A sports psychologist who works with elite level athletes from a range of Olympic disciplines described to me 3 key ingredients for change to happen. I can, I care, I understand, and I will go through each in turn. He described asking the patient 4 key questions to build their understanding and clarity. 1, why are we doing this? Identify their gaps in their understanding within their capacity. 2, what if we do nothing or carried on as we are doing? What is currently happening? What are we noticing? Help spark imagination in people. What's most important now and going forward? The individual can then generate what's most important to them. Discuss the pros and cons of change or no change, and ask them to rate the importance of change, for example, on a scale of 0 to 5. Ask them why they've chosen that. Explore the reasons for this can help identify the barriers that are needed to change. This is based on a 4-box decisional matrix used in motivational interviewing techniques. It helps people see the logic in what they need to do and for rational thinking. I care is implicit, it's a driving force. It brings emotion and energy. Clarity plus energy equals good things. As health professionals, we need to be black and white about the risks of not following the treatment, but also show empathy and care in how we give the message. So 1, what would life be like if we get this right? What does it feel like? What would it be like for you and your family? Stories are often stories are a powerful way to get people to care about the message. Finding the right story can help the person find the connection. Perhaps even keep a little black book of success stories. Possibility and vision can get people engaged. It helps build a trusting and positive relationship. I can appeals to their confidence and is about having ability. Again, you can ask them to rate their confidence on a scale and use this to help find a solution. If I want to, I can. It's about acquiring and having the necessary skills. Find a reference point. Have they done it well before? Remind them of that and find out how they did it. Ask them what is success going to look like. And if they do one thing well, encourage them to do it really well, build their confidence, pick up on these small victories and celebrate it. In 1989, Shiloh, Wiseman and Levy proposed a 4-stage model to define the reproductive stages of women with PKU and suggest that medical and healthcare support for each woman should be defined according to what stage the women are at. The first stage is prevention of unplanned pregnancies, where the focus should be on information and support. Prevention requires planning and rational decision-making. Advice against an unplanned pregnancy is not enough. Information on contraception and how to access it and family planning is needed to support it. The second stage is information relevant to reproductive decision-making, such as the risks and effectiveness of treatment. Women should be able to explore their choices. Feelings of confusion or being overwhelmed can cause indecision, which could lead to risk-taking. The third stage is about the details of starting the diet, making the decision to reorganize how they are eating and how to accommodate the diet into their life. For some, restarting the diet as an adult can be a public declaration they are planning a pregnancy both to the clinic and those around them. She must acquire the skills for the diet and in some cases have the appropriate finances in place to obtain protein substitute and low protein foods. Should a woman fail to get back on track with her diet, she either falls back to stage 1 or 2 or continues on to pursue a pregnancy. The fourth stage, after achievement of diet initiation, preferably prior to conception, the woman continues the diet throughout her pregnancy. Following the pregnancy, women may find it difficult to transition back to stage 1 for those who feel after having a good birth outcome, the problem of maternal PKU has been solved. So with this stage in mind, what strategies can be put in place to help women overcome the challenges? We can provide educational forums that address all stages of the maternal PKU life cycle. Group education forums that include adolescents and invite women who've had a good experience with their pregnancy can help increase knowledge and skills, improve metabolic control, and provide peer support. In 2018, my colleagues Carolyn Dunlop and Karen Lang and I held an education day for young women on pregnancy and PKU. We invited some women who had had successful pregnancies who brought their young children and described their experiences. A specialist midwife who works with teenagers and young adults discussed contraception and future pregnancy planning. And our specialist midwife, Cindy Horan, talked through the stages of conception and pregnancy. The day was very well received with positive feedback and we plan to repeat it. An interesting and important comment was that they were feeling too scared to plan a pregnancy, but now felt reassured. Video technology can also be utilised for one-to-one or group education. Perhaps develop pre-prepared video training on aspects of the diet that you can send links out to your patients and even for the wider family members to watch so they can better support the mother. In the US, there are maternal PKU camps available as a means of education and peer support to young women. Home visitation programs such as the Resource Mothers program in the US, which can provide at home or at work assistance, a visiting nurse to collect bloods, review food diary, assist with medical foods or food preparation could help address difficulties experienced by many women. Brown et al. In 2002 observed that many women often lose contact with metabolic clinics or return only once they become pregnant. And it was recommended that efforts to advise women to plan and prepare and return to diet before conception and sustain the diet throughout their pregnancy should extend to the family doctor, obstetricians, and pediatricians. Also, knowledge of obstetricians regarding maternal PKU should be evaluated. Until recently, we had 25 years of combined midwife, dietetic, and consultant clinic. One of our student dietitians carried out a qualitative study on our maternal PKU service. The feedback was that their local midwife did not have a lot of knowledge on PKU and pregnancy. Now the clinic has stopped. The current plans are to have a training session to midwives on PKU and pregnancy. And of course, implementing a structured transition process from child through to adult healthcare will empower young adults so they are able to take on responsibility for self-management of their condition. For women who are planning or have become pregnant, do try and identify and remove the barriers to adherence early on. Identify those patients at particular risk. One of the positive outcomes of the COVID-19 pandemic is the rapid move to using e-health technology for the majority of appointments. Video appointments save on travel time and costs and could therefore improve attendance and engagement at clinic. Again, video tools for education. Social media, there are peer and professional-led groups. Some of our women do follow peer groups that aren't monitored on social media, so caution needs to be used. In my experience, several times I've heard women say that they have heard that diet is not needed before pregnancy as long as levels are under control by 10 weeks. And one pregnant lady who was not achieving desired levels had read on social media that another girl no longer needed to follow a strict diet throughout her pregnancy and her baby was fine, so she didn't need to. So it's important to limit confusion of advice. Use email and text reminders for appointments. Do liaise with the GP, midwife and obstetrician, updating them on the patient's progress so they are aware as to how well the patient is following the diet. They can help support, but must be done sensitively. For finance, a charitable sector may be appropriate. In some cases, social work can help maximise financial support that is given. And ensure we provide more psychosocial support and encourage practical support from the partner and wider family to get involved. Preparing meals, help with menu planning, posting the blood spot, help prepare their protein substitutes. Strategies to improve adherence and metabolic control that I have found helpful include providing one-to-one teaching for both pregnant and preconception mothers on aspects of the diet that they want to know more of. Using our on-site education kitchen, our dietetic assistant has provided training on counting and measuring exchanges, on low-protein cooking, has given supermarket tours, help with menu planning, and has produced pictorial guides to help give them the necessary skills, confidence, and inspiration. I have provided prepaid envelopes and pre-prepared blood test forms, so all they need to do is take the blood spot, record the date and time, and post it. However, some still need frequent reminding. We've had the community midwife, the dietitian or dietetic assistant collect the blood spot. This has helped at least to get a regular result and enable more timely intervention. In one challenging case where finances and adherence were difficult, using charitable funds, we were able to provide some ready prepared low protein meals. At the start of an unplanned pregnancy, where I know dietary quality and choices are already limited, I've driven out to the patient's home and provided an emergency stock of suitable supermarket foods that are allowed freely, and a starter supply of low-protein prescription foods that we've either had stocked at the hospital or able to provide from one of the specialist home delivery services. Once I've used a hospital admission to bring a struggling pregnant mum fee level into range. She was previously off diet since childhood and had a very limited diet. During her admission, we involved her in devising the menu she received, and this was something she could then replicate at home. One-to-one teaching on aspects of the diet were given, a supermarket tour and shop, so she could be discharged home to self-manage her diet more effectively. Women will sometimes ask if they can be put in contact with other women who have gone through pregnancy for some support, and I will arrange this or suggest it. Many seem to find their own support on social media. We've trialled sapropterin in 2 cases where the women were unable to adhere to diet, but neither responded. However, I have tried all of the above with one patient, and despite the hard work of all the professionals involved, we were unable to achieve the fee levels in the safe range. In the situation when our team have struggled with patient engagement and there has been poor adherence, a referral to social work has been made as a means of finding better ways to support the woman through her pregnancy. Social work provided support with shopping and meal provision. They helped ensure transport to medical appointments. They maximised her finances, improved their accommodation, and ensured the children were put into the most appropriate nursery that also supported their own health needs. The other side is the ability to intervene if there's deliberate non-compliance and the need to protect the unborn baby. It's balanced by the mother's right to do what she wants, even the wrong choices. Referring to social work can cause upset with the family, so needs to be done with empathy and without threat or intimidation. We do, however, need to be frank and say we have a professional responsibility to both mum and her baby, and reassure the mother that social services are there to help support her throughout the pregnancy, as it is a challenging time. But at what point do we get social work involved? When do we refer? How many opportunities do we give the mother before going down this route are questions that still need to be answered. Safeguarding of unborn babies in the UK recommend early intervention and early help. As soon as concerns have been identified, which indicates the unborn is at risk of significant harm, and no later than 13 weeks into pregnancy. The National Institute for Clinical Excellence, or NICE, guidance on pregnancy and complex social factors aims to identify and describe best practice for service organisation and delivery that improve access, overcome barriers, and facilitate maintaining contact throughout the pregnancy. This guideline was intended for 4 exemplar populations that are at risk of poor pregnancy outcomes: substance misusers, recent migrants, refugees and asylum seekers with little or no English, and young women under 20 and women experiencing domestic abuse. This guideline is due to be updated, and topic experts are recommending it could be expanded to include wider groups of women with social factors that aren't currently captured, including homelessness, mental health and personality disorders, and fetal alcohol spectrum disorders. Should we as a specialist group be contributing to this update? It would highlight this at-risk group more broadly to relevant healthcare professionals. There is a NICE guidance on diabetes and pregnancy. Should there be a specific guidance document on maternal PKU? So to conclude, all healthcare professionals need to be aware of and understand the barriers to adherence in PKU pregnancy. There should be targeted interventions for all stages of the maternal PKU life cycle. Women should have access to psychological and other forms of counselling, such as genetic and family planning. Women should have access to non-dietary treatments pre-conception, throughout pregnancy and postnatally to ease the burden and minimise the side effects of elevated phenylalanine. Finally, there should be specific maternal PKU guidance document for health professionals that addresses how access to care can be improved, how contact can be maintained, what additional support is needed, and what additional information should be provided for women with PKU during pregnancy. Thank you for listening.
Sarah, that was an absolutely wonderful presentation, very detailed, very practical, very helpful in every way. Now, before we introduce you back to the platform to take a few questions, I think we have one more poll for our audience today. But Sarah, absolutely wonderful talk, and it is time to take some questions now. We've had lots of questions coming in. And I'm certainly enjoying seeing all these pregnancy questions again after a little time of not looking after patients. But let's start at the beginning, because one question's come in from Anne Daly asking about working teenagers. It would be interesting to see your take on educating teenagers in general about pregnancy, but specific advice on contraception. What do you think we paediatric people should be doing with our teenagers on pregnancy?
Well, as I understand, sex education and contraception is discussed in schools. So they're already talking about it and thinking about it. It's on their minds. And I understand the teenage pregnancy rates in the UK have been falling significantly with campaigns in schools. So I think it is something that can be talked about in clinic. And I think certainly mentioned to parents earlier on, perhaps, to highlight the future risks and the implications should a girl get pregnant. But yes, it is a question that we would ask in clinic, and I think the recommendations are at Scottish Government level that people giving sex education advice should have the necessary skills and attitudes and confidence to do it, and perhaps that's something that we should try and tap into for our clinics.
No, and it is interesting, because I was involved in writing up the paper on that the NSPKU did on the survey looking at women's views of pregnancies, and there's some very strong comments, very striking comments from a lot of women. But one of the things they often talked about, that the education that was given in clinics as teenagers, and even as they was going into adult clinics, that the metabolic team often considered them first and foremost as a baby making machine, and considered them second as a person in your own right. And that really hit me, that we put a lot of focus on this. Do you think sometimes we put too much focus on this? Particularly, some of the women said, we didn't want to have babies, but nobody maybe asked them that. And what would be your take on that?
I can see where they're coming from with that, because it's often a question that's asked to women when they would come to clinic. Is contraception an issue, and explained with the risks, and it's sort of to drum that message across. But at the same time, I suppose it might be difficult for the person hearing that all the time, and that it's expected of them to be in a relationship and to have a family. I think it's perhaps maybe trying to find the right balance.
Isn't it? Yeah. Sometimes not easy in reality when you're trying to do your best, but it is a consideration that we all have to have. Now, a couple of questions have come in about new therapies and pregnancy, and I'm going to take each of these in turn. And one is about sapropterin, and again, it's emphasising, Sarah, as you did, because we got people listening from the UK who are very aware of the policy and people from outside the UK. So just to emphasise, before I give you this question, is that in the UK, we're actually only permitted we only have an approved policy to use sapropterin in pregnancy only, but not outside pregnancy, including the preconception period. But the question that has come in from Emma is, should we be using it in the preconception period? And, you know, how did they get it before pregnancy? How possibly could they get it before?
Well, I think my presentation hopefully explained why they should get it pre-conception, because of all the demands and stresses of trying to stay on diet, and it's an extra support for them. My thoughts would be twofold, perhaps, whether local health boards can be approached for a request be put in place for sapropterin, and whether as the charity or the patient support groups can approach government like they have been to try and make this more available for people in the UK.
Yeah, and it is just to update people. This doesn't apply to Scotland, of course, but we're waiting for NHS England to give us an announcement anytime now on whether we have got sapropterin approved for all age groups with PKU. I think movement is afoot in Scotland, and NICE will be making a decision as well in February. So there may be light at the end of the tunnel, but I agree with you. It is about trying to do an individual funding request if we have a patient who's particularly struggling. But what about sapropterin is one new therapy, and it's the only potential that we have in the UK. But Alex Pinto has asked about new therapies in general during pregnancy, things like pegvaliase. Do you have any thoughts with that?
With pegvaliase in the UK?
Yeah. Well, we can't use it in the UK, obviously, right now. I think the only country that's practically using it in Europe is Germany, Hamburg, and obviously it's used in the States. I mean, I think my understanding, and this is where we'll bring Jerry in later, I think, and I'm going to put this question to him, is that pegvaliase isn't permitted in pregnancy, and I think if women are given pegvaliase that they have to stop it during pregnancy. The one new potential, not a therapy, but aid on the horizon that may really help us in pregnancy is own blood Phe monitoring. If we had own blood Phe monitoring that the women could do themselves at home, what would be your view on that?
Well, I think that would be great. It would give them that bit more independence. I think for some women, they like to do things by themselves and have as little communication with the dietitian as possible, and that would enable them to do that and have that greater independence. And in fact, someone today asked me about having home monitoring so they could get an immediate results rather than having to wait a few days. So it would make a big difference.
It certainly would be very helpful during pregnancy. I was fascinated, Sarah, that you put, this is a very British thing, but you put stamps on your envelopes. And oh, you know, we would love you. And do you think it's made, you know, I believe that people hang on to samples before they post them because they haven't got a stamp. But do you think it's made any difference to your women during pregnancy that you put a stamp? Have you got any evidence that it's improved them actually doing the bloods, or you getting the results more quickly?
Sadly, Anita, I haven't seen any improvement with doing that. I've done it with several women who have struggled, and I know that finance is an issue. But as I said in my talk, they still need prompting, and can still be reluctant to send in the blood spots. So I'm afraid I've not been able to demonstrate any improvement with that.
Yeah, we have a question that's come in about first and second pregnancies, and maybe you've got a mother who's had very satisfactory control during pregnancy, but then she goes on to have a second and third baby. You know, how do you engage them in future pregnancies?
When they've had satisfactory control in the first one?
Yeah, do you find it ever deteriorates in baby number 2 or 3, the control, or does it run smoothly, or is it different for every woman?
I've mainly found that women find it a bit harder to be adhere as well to the diet as they did in the first one, and they'll always say it was much easier the first time around, I'm struggling this time. They still do remarkably very well, but they do seem to struggle that second time. And whether it is because they feel everything's worked out fine before, so it doesn't give them that same strong drive to adhere to the diet. Yeah,
it is interesting. I'd like to see a little bit of work on that, looking at second and third controls in comparison to the first one. Now, this is a huge compliment to you. We've got a question in, or more of a statement, that you've encapsulated the challenges, time and resources required really well to take care of maternal PKU, and I'm sure everybody would echo that. But have you considered using this material to write a document to send to commissioners to get more support for adult services?
Yeah, very much, and I hope it will lead on to further work to make it a more official document to raise the awareness to other health professionals involved with looking after pregnant women.
Yeah,
so that we've got more support as well.
I mean, it's really, really clear. Sarah, if you're able to take a couple of more questions, the motivational work that the elite sports nutritionists came up with, psychologists, was fantastic. Do you use this with all your patients? How effective do you find it? And do you think it should be used with other patients other than PKU or outside pregnancy?
This advice came to me just very recently on speaking with Charlie Unwin, and not regarding this, he said you can use it in all aspects of life or in clinical practice. And it just blew me away, what he was describing to me. So I would like to start using it in my day-to-day practice. At the moment, I would use the sort of first-line behavioural change techniques, active listening, reflecting back what the person said, paraphrasing to show my understanding, and I think it's useful for people to hear back what they're saying out loud. And of course, I try to make the counselling patient-centred, and that I'm discussing what their concerns are. But motivational interviewing is something I would like to get more training on. And in fact, I've spoken with our psychologist in paediatrics, who has suggested providing some motivational interview training to the wider team, and has in fact signposted me to a consultant clinical psychologist working in maternal and neonatal health to see if they would actually be able to be involved with some of our pregnant women.
Yeah, no, that would be fantastic. And do you think that's the sort of training that should be for all the metabolic team, and that all metabolic members should, you know, apply the same motivation when they're speaking to patients in the same way, so it's a united front?
Yeah, so it's a united front, and we're working together to support the patient, and help the person feel that they can open up to discuss their issues, and that they're feeling supported, and that they've got a say in their treatment. Yeah.
I mean, one of the things, and I think I'm going to make this a final question. Sarah, again, we could talk all night and about this, but hospital admissions and pregnancy, and you've got some quite strong views on that one, and in terms of, you know, the problems in admitting patients with PKU to maternity hospitals. And I think it's probably across the board with admitting any PKU patient to any hospital bed. We've got a problem of people not understanding things. How can we overcome some of the problems of hospital admissions in general? What can we do as a profession to improve somebody's stay and the quality of it, and making sure they have the treatment that they should have?
Yeah, I think taking into account previous experiences and getting feedback from the patient of their stays, and liaising back with the ward staff, and I think in this case we spoke with the ward sister afterwards to explain how the patient stay went and how we could make it better for future. So.
Yeah, it is a bit of a challenge for us, isn't it? And it certainly it would be interesting to do an audit of any hospital admissions during pregnancy to see, was it beneficial? Did it really make any difference to the final outcome? And it would be an interesting piece of work. Sarah, you've done a wonderful job this evening, and I've learned a huge amount, and I've thoroughly enjoyed the last hour listening to you and talking to you. So good luck with all of your work, and I'm sure we'll talk to you soon. Thank you.
Thank you very much.
And now we're going to come to our final speaker for the last 2 days. As a final speaker, this is a speaker we're going to welcome back onto the podium. It's time for Professor Jerry Buckley again. I'm really looking forward to this, and I'm not going to read through all his CV again, because we went through this yesterday, which is incredibly impressive in any way. But you know, Jerry's a guy who's got many strings to his bow. He's a real sort of powerhouse in metabolic disease, and not only does he do a huge amount of work on the fatty acid oxidation disorders, I think he does research on absolutely everything. And certainly I would add PKU to a very big string and a very strong string to the bow of work that he actually does. And certainly Jerry has done a lot of groundbreaking work on PKU. He's been involved in sapropterin in the past, done a lot of work on peg valiase. I may be wrong, but he may have been the first person to sort of develop the pig model for PKU. Is very much involved in many of the new therapies that are being developed at this moment in time. He works very closely with the NPKU Alliance and the Canadian PKU societies, and does a fabulous job. The title of his presentation today is PKU, Modern Therapies for an Old Disease.
Thank you, Anita, for that introduction. And I'm again pleased to be able to talk to you about some of our work in PKU. Unfortunate that we can't do this in person. And the title of this is Modern Therapies for an Old Disease, because I'm going to be reviewing for you a broad spectrum of clinical trials that are ongoing now with PKU that I hope you'll agree by the end of this talk that there's really great hope that eventually this is a disease we're going to cure completely. And just to throw up my conflicts of interest, or as I prefer to call them, opportunities, research funding from these groups of disorders, and I do some consulting for biopharma. I'll just mention that my Ultragenics ties relative to the triheptanoin studies are all scientific. I take no consulting or personal income from them. I don't need to remind this audience much about PKU. It is, of course, an autosomal recessive condition that leads to deep deficiency of the hepatic enzyme phenylalanine hydroxylase. Incidence anywhere between 1 in 10,000 to 1 in 15,000 in most populations. Though in the UK there are some that are quite more frequent than that. And the pathophysiology is pretty well established, although we don't know why phenylalanine is damaging. We do know that an increase of phenylalanine due to that decreased PAH enzyme leads to not only an increase in phenylalanine, it's a decrease in tyrosine, and then the secondary effects that led originally to the name of the disorder, the phenylpyruvic, which is further metabolized to phenylactic and phenylacetic acid in the blood. These guys aren't toxic, so it really is that the phenylalanine that we think is the toxic compound. Because of early identification of and treatment of siblings of patients with PKU, it was recognized that early treatment could normalize intellectual outcome, and of course that was the reason for initiation of PKU as the first newborn screen disease now over 50 years ago in the U.S. And even though the early introduction and lifelong treatment of patients with classical PKU can eliminate the worst of the intellectual deficits related to the disease, it still leaves its mark on many patients. First of all, it's very hard to keep that diet for life, and most individuals by the time they're adolescents or young adults are well over the US recommended lifetime target of 360 micromolar, and even the European target of 600 micromolar. Many of them are off diet completely, probably half or so with levels of greater than 1200. And the neurocog effects of that in patients with early treated PKU are quite characteristic. This executive function deficit that we're all used to seeing, that inability to sort of more complex plan to get to your day through step 1, 2, 3, 4, 5, 6, and instead wandering off and eventually coming back. And many of these patients just have really chaotic lives. Psychiatric symptoms, depression, anxiety, mood swings, behavioral issues, ADHD, and even a higher level of schizophrenia, and some milder neurologic abnormalities that can be present in these individuals, especially the fine motor issues introduced by quite a significant tremor, can be present in various combinations in individuals early treated, and in some cases they're not there, but we don't understand the difference in those two groups of patients. The end result, however, is that the overall disease burden in PKU remains. It's not only the health status in the individual and their psychological function, but of course the impact on their family life, their social function, the dietary restrictions that these individuals need to follow if they're going to stay on a low phenylalanine diet for life, and the need for these fee-free supplements that are expensive and life limiting to some extent. But you know, the exciting thing is that when I meet with families now for the first time with babies identified by newborn screening, I don't talk to them about lifelong treatment anymore. I talk to them about keeping their babies in good enough control for optimum outcome, so that when we are able to cure this disease, their child will have the least possible damage. And for my older patients, say, look, don't give up. We've got a lot that's going to come down the pike in your relatively immediate future. And in drug development, you know, that's sort of 10 to 15 years. That's immediate, but nonetheless, that's way better than anything we've ever had to say before. So what I'm going to do is I'm going to just give you a quick overview of the couple of things that are out there right now, and then come back and talk about the clinical trials that are ongoing. The first thing I'll just mention these existing ones very quickly because you're familiar with them. The first one is the large neutral amino acids. Of course, these are the amino acids that compete with for phenylalanine at the transport in both the gut and the brain. And the idea here is that if you flood the gut with lots of this stuff, maybe you can decrease the uptake of phenylalanine, and maybe even if you don't block it 100% there, you can decrease the uptake at the blood-brain barrier. And sure enough, this probably decreases gut uptake under optimum circumstances by maybe 40 or 50%. And can be used in conjunction with a low Phe diet to help improve the Phe tolerance, but it's not going to be the difference between a normal diet and a restricted diet. And remember that at least for the time being, we mostly limit this to older children and adolescents and adults because of the concern about having problems with the neurotransmitter balance in younger babies and growing children, and especially in pregnant women. So this has limited uses. A glycomacropeptide, or GMP, is a relatively well, I guess it's been around for a little while, but it keeps getting improvements in its formulation. This, of course, is a peptide product of cheese making, a product of whey, and the peptide itself has no phenylalanine residues. However, the isolation of it from the milk product leaves a little bit of other proteins behind. And so it's not a Phe-free product, even though you might think it should be based on the amino acid content, but it is a very low Phe product. And the impetus here is that a lot of dietary studies have shown that the quality of natural protein is better than individual amino acid supplements, and that GMP it's hoped, and in some situation, in some studies, it's been shown that it does have some beneficial effects. At the very least, it allows production of low Phe specialized foods that can allow more protein intake, but lower, but keep the Phe levels here, as you can see, the Phe level in the blood and the protein intake from food in a better controlled range, here in the range at least below the European level. And then the two pharmacologic agents that have been approved sapropterin, Kuvan, and pegvaliase, phenylalanine lyase, an enzyme substitution therapy that decreases the Phe in blood. Sapropterin has been very well studied now, and somewhere between a quarter and maybe up to a half of patients with classical PAH deficiency have some sapropterin response. However, it's mostly partial, and the usual statistic that I use is that about half of patients will respond, and those patients will reduce their Phe levels by no more than half. Now, if you've got a milder or a moderate PAH deficiency, your chances of responding are higher, and your chances of responding completely are higher. In the U.S., the current, and I think the European guidelines are the same thing. That really it's worth trying everybody to see if they're PAH deficient, unless they have two bona fide null alleles. You know what their genotype is, and they just don't make any protein. Phenylalanine, pegvaliase, phenylalanine ammonia lyase conjugated to polyethylene glycol, has the advantage that it can decrease Phe in any patient for any reason, whether they have classical or milder Phe. And here, in one of the clinical trials done to look at efficacy as defined by reducing Phe levels, what you can see is patients started here in the looking at Phe levels in the red on treatment with an average level of near 1,400, dropped down to near 600 on treatment. They were then randomized to a double-blind placebo, and the individuals who were on the placebo, of course, increased their Phe levels. And then once you stopped that, they went back down. Once you moved them back over to active enzyme, they went back down again. And then over time, they were able to drop. Most people were able to drop down to close to the 360 level that the U.S. guidelines suggest, and then it lasted long term. Here up to 49 weeks. It's now way beyond that in most patients. And the most telling feature here that I like to show is this ADH scale, which, just as you can see, given every day, every time they come in for a clinic visit, paralleled the Phe levels, except for this very short period on placebo. So it works. The problem is that it requires injection of at least one injection a day if you're on 20 milligrams. But some folks require 40 and some even 60 milligrams. And so that can be 2 or 3 2 ml injections a day of this really viscous stuff. So that's very difficult on patients. Plus, there's a fairly significant level of hypersensitivity reactions. It tends to drop with long-term use, but it doesn't go away completely. And of course, this is only approved for adults. We can't use it for kids. So it's a good drug, but it's not for everybody. And that brings us to what else is available. Well, there's a lot that's coming down the road, and I'm going to break this up into categories of nucleic acid therapy, and this includes gene therapy and mRNA therapy, cellular therapy, small molecule therapy, and then finally I'm going to finish up with update on our attempts to develop a home phenylalanine meter. So the first drug I'm going to talk about is a acid stabilized phenylalanine lyase produced by Codexis, now merged or acquired by Nestle. And this is, as the name implies, a drug, a form of phenylalanine lyase that's designed to be stable in the acid pH of the stomach, get out here into the small intestine, and hopefully digest some of the phenylalanine that's taken in the diet. When it turns it into tranexamic acid, the same reaction that occurs in the blood, and would hopefully decrease the Phe load from the diet. This is in clinical trials now. At least in the United States, I think it might be going in Europe as well. I'm not 100% sure, but we'll be seeing results from this coming down the road. Gene therapy, after being around the corner for every 5 years for the last 30 years of my career, is finally here. There's a gene therapy trial ongoing for homology. Is the company that's doing that, and BioMarin is getting ready to start one in the United States, probably right after the first of the year. And I don't have human data to show you, but I'll just show you that in a mouse injected with one dose of the low dose of this stuff versus a high dose, you can reduce their phenylalanine levels down to lower levels. Here, they actually perfectly normal. This is in phase 1 now. There have been some early data released by the company showing that patients are at least responding partially, and we'll hopefully get more data on that release in the not too distant future. I'll be talking later today, real time, for the National PKU Alliance Family Group here in the U.S. With representatives from homology, where I'll be talking about their results. So when you see this, you should be able to go back to that NPKU-A webinar, which will be recorded online, and get some more updates on the human side of this trial. Our cells hold our genes, of course, and so if you can give an individual a completely new liver cell, you can fix them. And so we've been here in Pittsburgh looking at the possibility of using hepatocytes, liver cells, for treatment of PKU. And in this case, you take a liver that is where the hepatocytes are healthy, but for one reason or other, the liver can't be used for transplant. We can isolate those hepatocytes, and then you can infuse them, it turns out, through the umbilical vein, which even in an adult you can cannulise it, it turns out. This requires giving the right upper lobe of the liver a little bit of radiation to induce some damage that allow the new hepatocytes to engraft. And when we do that, you can see here in the only patient we've done so thus far with PKU, we were able to drop her levels from about 24 milligrams per deciliter down to about 14. And this was an early study. We're now able to give many more cells than this, and we expect that the next patient that we do, we should be able to get them down at least to the 600 in the European guideline, and hopefully even lower than that. So this study is on hold because of COVID, but because it does require immunosuppression, but we're working on getting that up and running as soon as it's safe. We're also actually doing whole liver transplants in patients in Pittsburgh. We've done one. This is only for women of childbearing age with PKU out of control who want to have a child. And so it's very, very limited clinical criteria. But we've done one patient, and her Phe is not surprisingly completely normal. So that we know works. I'm going to talk to you next about a project or a drug that Synlogic is designing. And this is a drug that uses a probacteria, a probiotic that is an E. coli nissel. This is a normal bowel flora, and it's it's the active ingredient in a lot of the probiotics that you can just buy over the counter. Well, Synlogic has engineered phenylalanine metabolism pathways into that bug, and in a phase 1 trial where first healthy volunteers and then patients took either one dose or multiple increasing doses, and then this was done in the hospital, and we were able to look for the metabolites here. They have 2 pathways in there. One is generates is a PAL, and so this generates the tranexamic acid that we see in Peg-Valiase studies. And you can see the individuals with increasing dose here generate an increased amount of tranexamic acid. And you can also see in hippuric acid, another metabolite engineered into, or from the pathways engineered into here that this increases as well. Interestingly, this occurs even when the patients are fasting, and it turns out there's a significant enterohepatic recirculation of phenylalanine. It's in sky-high concentration in the duodenum, 5,000 micromolar. So even if you're not eating and you take one of these probiotics, it can work to decrease the phenylalanine level. And of course, if you're eating, we hope that effect is even greater. Synologic has done some modeling based on their pharmacokinetics, and they have calculated that they can probably reduce on a normal diet the amount of Phe being presented to the blood, and therefore the level of Phe by at least a half with the current generation of the bug, and they've just come up with a new version of their medication that has even a higher capacity. So I think this is a really promising looking drug, something that you might use in younger kids where you were not so interested in doing clinical gene therapy, but didn't want to do injections, for example, of pegvaliase. The final medication that I'll mention is mRNA therapy, and unlike gene therapy, this is the actual messenger RNA. It's synthetic, stabilized nucleotides that you can give, that's encapsulated in a lipid formulation that you can inject via IV, and it goes straight to the liver. And this is not, this doesn't show PKU, but it shows some experiments we've done with a different disease, VLCAD deficiency. For those of you who saw my fatty acid oxidation presentation, I showed a version of this slide, and we can get normal activity in a mouse that lasts up to probably 2 weeks here, and maybe even longer. So if you did this for phenylalanine hydroxylase, you could get by with maybe a once every 3 to 4 week injection instead of an IV injection instead of a daily subcutaneous injection. And just to prove that this is viable, the same company, Moderna, actually has a therapeutic mRNA in clinical trials for methylmalonic acidemia, MMA-CoA mutase deficiency. And as with most metabolic diseases, they can cure a mouse with an every 3 week injection. And so the clinical trial is ongoing in the U.S. And we'll see what that looks like. I know of at least a couple companies that have been interested in making a phenylalanine hydroxylase therapeutic mRNA. So I think you'll see it coming down the road, an option rather than the sub-Q injections of the phenylalanine lyase, the pegvaliase. So finally, just a quick note about a home Phe meter. This has been one of those holy grails, and it's been on the horizon for at least 10 years. We were involved with an early trial with BioMarin that didn't pan out, and now we're working with a company called Apotec. They use DNA, small molecules that just naturally fold into all sorts of shapes, and if you screen, you can find something that binds almost anything. And they, in fact, have found an aptamer that binds phenylalanine with very high specificity, and have used it as the basis of a home Phe monitor. This is a picture of it. This is the cartridge that this little thing has got a pin prick in it, and you prick your finger like you do with a glucometer, and you fill the capillary. I'm sorry, there's a capillary in it. You fill the capillary with blood. You put that in that cartridge here in this little piece. You stick it in this this reader, which is about the size of, I don't know, 2 bars of soap stacked up on each other. I don't know if I'm going to be visible to you, so I may be doing shadow puppets here to myself. But it's a box that's about this, a cube, it's about like this big. So it's not handheld, but it's very portable and it's battery operated. It communicates via Bluetooth with your phone, and then that uploads the values to, it gives the patient a readout in 20 minutes, and it uploads it to the center so that you can have real-time communication with the center. You can see that it's very, very linear reaction from about 1200 down to 0. And so this meter is programmed to tell a patient that what their level is, as long as it's between 200, I think it's 200, and 1200. If it's lower than 200, it's not validated yet for any lower than that, so it just says you're below 200. And if it's above 1200, it just says it's above 1200. So we're involved now, getting ready to start a clinical trial. We've had some COVID slowdowns in the manufacture of that, but we're getting ready to start a clinical trial where we're going to compare patients with classical PKU off and on the monitor, individuals who have Phe levels that are over 600, and they'll be randomized for 3 months to either get the Phe monitor or not. Those who don't get it at the end, after 3 months, will cross over to get it, and then we'll check and see whether there's a difference and whether it makes sense to use this in clinical practice. I'm just going to skip over this. We have a phenylalanine hydroxylase deficient pig model that we've generated. It does not have neurodevastation the way untreated PKU humans do, but it does have some symptoms. And we can show, for example, that it's got a smaller brain here, and you can see here compared to the hindbrain, and here in the forebrain compared to normal. So there's a ton going on. There are lots of clinical trials in the pipeline. This is what I've been able to accumulate and are either in preclinical or in phase 1 through 3 in the U.S. Not sure how many of these right now go over to Europe, but eventually they're certainly going to make it there. And with that, I'm going to say thank you for your attention, and I understand that we'll be switching live after this, and I'll be available to answer questions for you.
But Jerry, an absolutely, fantastic presentation. You gave us a whistle-stop tour of new therapies, and certainly helped clarify many points. Again, I don't know where to start with all the questions, because you've got plenty. But we've got an interesting one, and this to you isn't a new therapy, of course, because you've been using it for some time and had it in research for God knows how long, but one on pegvaliase. And this is a question, I think, from Daly. If pegvaliase is viscous, could you have a pump like diabetics, but less painful and easier to give, and give it via a pump, and also do some 24-hour Phe monitoring at the same time? I mean, what is that possible?
You know, this was a pipe dream early on in the development of the product, but this stuff is very, very viscous. And so the ability to use a pump with a relatively fine capillary has been suggested, something that you might clap onto your forearm and have it infuse subcutaneously over a short, maybe an hour or something like that. And something like a sub-Q pump would also work. But the problem with that is you'd need to, if you're giving 6 mLs of this stuff a day, that's a big reservoir, unlike the pumps that are used for insulin. So I wouldn't put it past some a brilliant MIT engineer to be able to come up with something, but so far nobody has.
No. Can I just ask, what's the youngest patient now in the States that you've used pegvaliase on?
Certainly 16, and I think I know of some folks who've gone down to 14. It has not gone
Okay.
into any lower than that.
14, yeah.
Adolescents, basically.
Yeah, okay. I thought you might have moved it down a little bit. And yeah, so down to 40. Okay. Again, I'll stick with questions on PEG valiase just for the moment, and we'll move it on to the real new therapies. But with PEG valiase, how often do you recommend monitoring Phe levels in patients who are clearly responsive, which is the majority to PEG valiase?
Yeah, it can take 6 to 12 months for them to equilibrate for whatever reason, probably largely immunologic. And so during that time, we monitor them pretty carefully. I like to do it at least once a week. We don't change their dose very frequently, so it doesn't really make sense to do it too much more frequently than that. And then after that, still going once a month is quite reasonable, though some of our patients don't adhere to that, as they sort of view themselves as being on somewhat cured. They can eat a lot, but a lot more Phe than they used to. But it's extremely variable. Sometimes we've had patients on PEG valiase for a long time with stable Phes, and then one time they come in and their phenylalanine level is 900 again, and it's like, well, what's going on? What's different? They can't easily identify it. We don't really adjust the dose until we get 2 of those in a row. So we check it in a couple of weeks, and it's back down again. So it's quite variable.
And then just to give us a picture of your clinic, Jerry, how many adults or patients over 16 or 14 or whatever are actually on PEG valiase therapy?
We have, it's only been approved in the States for close to a year now, and we've been moving up slowly and offering it. I think we're probably somewhere in the 20 to 30 range right now, but I may be a little bit behind on the totals.
Out of how many adults? So just to give
that's probably about a quarter of our active adult population right now.
Yeah.
We probably have 2 or 3 adults out in the community who don't come back for every one that we're seeing actively in the clinic.
Okay, no, excellent. And coming back to the real new stuff, and what do you think is the most promising, novel, short-term treatment out of everything that you've told us about today? What are you putting your real bets on?
I'm not a betting person. That's why I play all the cards. I am absolutely convinced that therapeutic RNA will work. Everything that we've done with it for a variety of different diseases that we're looking at in the laboratory, the studies that the company has already published for MMA and PA, I think that is essentially a sure bet.
Yeah.
And the nice thing about it is you would be talking about a once every 2 to 4 week infusion. So it's not without its drawbacks in that you do have to get an infusion. But that's a heck of a lot better, I think, than a daily 1, 2, or 3 injections that we're doing with PEG valiase. I also quite like the Synlogic therapy, the probiotic approach, and they're working on the phase 1 trial that they did was both dose finding and safety, of course. And it clearly showed that they were metabolizing phenylalanine, but it wasn't powered to see what the effect was going to be. And they now have a 2nd generation design that probably has about double the capacity of the original. And even with the original drug, they were able to do some modeling that suggested that they could get on an unrestricted Phe diet the Phe level down to as low as 600. I think that's also quite a nice drug that you know you'd have to take a dose after every meal. But you know, it's not, if it's a reasonably tolerable medication. The original preparation did have some GI side effects. I think has potential as well. Gene therapy, of course, is the holy grail, and it'll hit there eventually. But it's going to be a long time before we get to the point where everyone can and should do that $1 million injection, which is what it's going to cost.
Yeah, and which of the therapies can apply to all age groups of patients, do you think? Obviously not in trials, but in the future.
I think the oral medications are the obvious ones to focus on there, and so we would be talking about the Codexis molecule and the Synlogic one. I think are both should be readily applicable to the pediatric population. It's a little hard to talk about giving an IV infusion to a 2-year-old, right? I mean, that's on a once a week or once a month basis even. So I like the potential of the oral medications, either individually or together in combination.
Yeah. And yesterday you talked about the possibility of combining therapies. And with all these new therapies on the horizon, do you think that there is any possibilities of combining therapies? Do you think they would be too expensive? People would pay for them? What is your view on this?
Well, expense is obviously a big issue, and it's hard to know what the tipping point is going to be for the system. Will one drug that gets you to 600 be acceptable? Would 2 drugs that get you to 200 be better? We've never been able to do those long-term follow-up studies, right? Because it's been very hard to get people down to the 360 in reality and watch them and see if they do better than if you stay at 600. You know, I think there was some data presented at one of the recent SSIM meetings by the Turkish group that in their immense population that showed patients at 240 were doing better than at 360. So you know there's some theoretical numbers that we have to look at.
Yeah.
But yes, I think the combination of one of these oral enzyme medications and one of the potentially even more potent chaperonins that are out there. I didn't mention, but they're on my little timeline chart there. There are a couple of new chaperonin molecules that are in development. One, sepiapterin, which is more potent than sapropterin in early studies, and then another molecule, unrelated molecule by Agios here in the U.S. that does have some mutation specificity, but looks quite potent. So lots of possibilities.
How far do you think the septitine one? I pronounced that one always wrong. But how far do you think the septitine one is off? Because they've done stage 2 studies. I mean, do you think that's viable in the next 2 years that might come online?
Yeah, I think COVID has set everybody back. They were looking to move into phase 3 trials quite a few months ago, and so I do think that if they're ready to go as soon as as COVID restrictions are up, that one could come sooner rather than later.
Yeah, no, that would be good. Now, the idea of liver hepatocyte transplants is quite popular here. And we've got a question here, would that be a complete fix? And it sounds great because there'd be no injections and completely no dietary restrictions. I mean, as you answer that, can you tell us how you would do the liver hepatocyte transplant? Would that be like an infusion that would be given to patients?
Yeah, what you do is you get a liver that has been turned down for whole organ transplant. Usually the reason for that is because of fibrosis. And that the hepatocytes in those livers are perfectly functional. And so our GMP cell facility takes those livers, breaks them up, dissolves the collagen, and isolates the hepatocytes, and you end up with what looks very much like a bag of red blood cells. And you just hang that at the bedside, and it diffuses or gravity flows, or you can pump it in through a vein. And our early attempts have been to do it through the umbilical vein, which is quite a cool technology. These guys can just go in with these little catheters, and they start squirting a little at a time, and it opens back up, which I find remarkable. But you can also inject it directly into the spleen, into the splenic vein. So there are lots of different options. The thing that has, two things have slowed down sort of our ability to recruit those patients other than COVID, which has put us to a halt. One is that you do have to prepare the liver to accept the transplant. If you just inject the cells, they have no place to go. And so we use a very low dose of radiation to the right upper lobe, and that causes just a little bit of hepatic cell damage, gives room for the new cells to take over and thrive. People don't like radiation, and so that's a little scary, and it has slowed things down a little bit. The other thing is post procedure immunotherapy. So it's very low dose. It is the same kind of therapy that someone, for example, with JRA or one of the immunologic disorders, the autoimmune disorders, uses, and they use that medication every day for days and days. And so it's years and years, and so it's actually quite mild, and there are very few side effects to it. But it still scares people. So we've had a number of patients in our non-PKU hepatocyte transplant trials. Only one so far in the PKU. The good thing about that is if gene therapy comes along and really works, we can just shut off the immunosuppression. Those cells are rejected, and an individual should be able to get gene therapy thereafter. So it doesn't commit you to lifelong immunotherapy, which liver transplant, of course, does. And I say that with a caveat, because 10 to 15% of patients with a liver transplant eventually come off of immunosuppression. So the body tolerizes to the new organs. Lots of moving parts to consider.
It's fascinating. And then you're moving us nicely on a link onto gene therapy here. And are there significant differences in the various gene therapy vectors that are being trialed right now?
Right now, they're mostly variations on a theme. They're all AAV derivatives. Some of them are the usual serotypes that you're used to hearing about that are naturally isolated. There are other serotypes that are artificially engineered to try to get around the natural resistance that some individuals have with the various AAVs. I think that in reality, what the utility of multiple different preparations is going to be is if you assume that everybody's going to be resistant to one or immune to one or more of those, you're going to need several of them before you can cover everybody in the population.
Yeah, and so right now in the studies, sort of what checks have to be done with the patients? I mean, a check for the antibodies, etc. Yeah.
Okay. Everybody gets serology to see if they're immune to the vector that's being used, and if they are, of course, they're not allowed in the study. And then we go ahead and sign them up for another study and for antibodies.
Yeah. And how many get rejected? For this, I mean, how many would you have to test possibly to get one to go through in a gene therapy trial? We're just getting it. We're even doing some work on gene therapy in Britain right now, Jerry, for once, and with the DMIMD product, I think at 2 centres. So I'm just interested how many patients would potentially get rejected?
Depends on the vector. It tends to be on the order of 10 to 15% of
Right.
individuals will react with
Yes.
any one vector.
Yeah.
But some of them are a little bit higher than that. Most of the current ones seem to be in that 10 to 15% range when you look at population studies.
Yeah, okay. I have 2 or 3 quick questions remaining for you, but I want to come back to Synlogic. And one of the things you mentioned was the high levels of phenylalanine in the duodenum. Where's that coming from?
It's the same phenomenon that you see in the renal tubules. So it looks like amino acids are being excreted into the duodenum and then reabsorbed distally. Now, I have no idea what the physiologic reason for that is, right? I mean, why on earth did our kidneys evolve into throwing everything out and then you just have to pull back in everything that you want? Well, it looks like the gut is a variation on that theme. And you can take somebody who is fasting, who's been fasting for 24 hours, so they have nothing in their upper GI tract, give them the probiotic, and you see them excreting metabolized phenylalanine, and it is because it is reacting with I guess you'd have to call it well, it's not an intrahepatic circulation, a duodenal colonic circulation, I suppose is the right terminology there.
Yes. No, thank you. That's fascinating. A question that really came up before was about new therapies and pregnancy, and I just really want clarification over peg-valiase and pregnancy. In the States right now, I'm guessing, would you stop peg-valiase if, or not, you would continue? And interesting. Tell us more.
Yeah. So there have been some pregnancies with peg-valiase already, and they've been carried successfully to term. It is an FDA Category C drug, which means that there's no information on it in pregnancy, but it is not prohibited. Yeah,
interesting. So you wouldn't stop treatment as a consequence?
Folks who, especially early on, who have started peg-valiase, or those who have been unsuccessful in keeping their fees under control any other way. And so it's like the liver transplant in a way, where the indication for the liver transplant is not phenylalanine out of control, it's phenylalanine out of control in a woman who wants to become pregnant. So peg-valiase is the same way. If an individual who would like to become pregnant or does become pregnant and is on peg-valiase, most of us here feel that it's justifiable to continue that, especially if they've been on it for an extended period of time without any of the side effects, the immunologic effects.
So that would be like an individual clinician decision, obviously, along with the patient itself. No, that's certainly interesting. That message hasn't got quite across the water yet, and but
I don't think there have been any publications, but there is a Kuvan moms type registry that's being kept, and I would assume that sooner or later we'll see some of that experience published.
Yeah, no, that is absolutely fascinating. The very final question that I've got for you is, well, it's a tip, really, I want from you, Jerry, because we haven't been very successful in getting funding for new therapies. We haven't got BH4 off the ground because the NHS have turned it down. Obviously, peg-valiase is just a dream at the moment. What would you say to us Brits to help us along the way in convincing our funders to get behind these new therapies?
Yeah, so if I knew that, I might run for political office, but I doubt it. I find politics particularly distasteful, no matter which side of the spectrum you're on. But I think you have to pick your battles. I guess the question that I would ask at this point is it too late to even worry about Kuvan? Given the efficacy profile, where you know, maybe half your patients will respond and they'll respond partially, are you better off just turning around and saying, well, if that's not good enough for you as an insurance organization, the government, I mean, let's just go straight to pegvaliase because it can fix everybody. Maybe just fight for a single drug that provides that potential benefit for everyone. That of course excludes the pediatric population for the time being, but you can probably get it down to the young adolescents. You know, there's been rumblings. I don't know if it's going to happen or not, but there have been rumblings in the U.S. about a pediatric study. But that would be the next logical step to say, and we'll study it in kids and see if it's something we want to use there. It's good, really pretty hard to I think convince the kids in the probably the under 10 or 12 age range to want to do that, and they're probably not so needy anyway. As if you look at the statistics on fee levels in the PK population. So I would like to be able to get it into the adolescents and then go from there, and then, you know, maybe while you're fighting that battle, one of these other ones will come on and be a better oral alternative to Kuvan.
Jerry, it's been a fascinating hour with you, almost hour, and thank you again for a wonderful presentation. Thank you for patiently taking all of those questions and answering them so honestly and so well. Really, really appreciate that. We've got a great insight. I've learned masses, so I'm sure absolutely everybody else has. But again, thank you, and good luck with the rest of the day and your meetings today. And I hope it's very successful, and to keep well. Okay, thank you
very much. And I hope this can be in person next year.
Yeah, I hope so too. That would be fantastic. Thank you.
Bye-bye.
Bye-bye. Bye-bye.